Good evening, everybody. My name is Ali Noorani. I'm an orthopedic surgeon. I work at the Royal London Hospital, but I also work at the Regenerative clinic, and my orthopedic practice is based at Orthopaedic Specialist. Today, we're going to talk about tennis elbows and concentrate on whether we should be injecting tennis elbows or not. So these are some of my affiliations. The ones that I want to talk about is actually USER. So USER is the European Society of Shoulder and Elbow Rehab. I'm the education committee there. It's a group run by physios, for physios with surgeons involved, offering what's the best kind of rehab as well as what kind of best management we can do for our patients. Now, for my talk, I like to acknowledge two people that work very closely with USER. One is my colleague Andrew Cuff, who has some of the information that has been provided in the slides today, as well as Leanne Bessett, who is a physio based in Griffin University in Australia. And some of the work that I'll be mentioning today regarding evidence is very much her work, so I need to acknowledge that. So let's talk about tennis elbow. We know that it is very common, right? It's present in about 3 to 5% prevalence rates, right? We know most of the patients that get it are between 30 and 50 years old, and it can last for a very long time. It can last for, sometimes as less as a few weeks, but most patients that present to us have had tennis elbow for at least 6 months. And there are some patients who've had it for many, many years. And even if it goes away, yes, of course, it can come back. So it is a very common problem for patients presenting in an orthopedic clinic, as well as in general practice, as well as to you guys in physiotherapy. So we see it, we all see it. And I know that when I asked the question earlier on, how many people in the audience have had tennis elbow, at least 20% of you put your hand up. So we know that it is very common in every population. Now, it's got lots of different names. We used to call it lateral epicondylitis. Maybe that is a bit inaccurate because condylitis suggests that there is inflammation there. But now we know that a better name for it is probably lateral epicondylar tendinopathy, because tennis elbow can't be seen as an inflammation, right? You have to see it almost like an injury. And once you start seeing it as an injury, you start treating it differently, right? Because you're not there to just take the inflammation away. You're here to actually treat the injury. Now, what is the etiology? So, at microscopic level, we see that the collagen fibers are disrupted, okay? And when that is done, when on the MRIs and other scans, you will see the tendon is looking thickened, angry, almost inflamed, but not inflamed. So what we call tendinopathic. But these small changes can propagate. They can become bigger. So the collagen fibers, the small tears can become bigger tears and can eventually lead to a partial thickness or even a full thickness tear of the common extensor origin. So we see a whole spectrum of patients. Some that have just thickening of the tendon where they have micro tears, all the way down to patients that have full thickness tears. So we do need to differentiate from other pathology affecting the lateral side of the elbow, okay? Yes, tennis elbow is probably the commonest thing that happens here, but there is radial tunnel syndrome where the radial nerve gets trapped in the muscles around the elbow. Usually that presents as pain slightly distal to the epicondyle, and usually there isn't that tenderness over the epicondyle. But just remember, there is a joint very close by, so the radiocapital joint is right there. So if patients have trauma or, you have to look to see if there is any bony problems. So therefore, apart from the assessment, imaging can be very, very helpful to tell us exactly what's going on. Now, there are other problems as well, like cervical pain being referred down to the elbow, and of course, in rare cases, inflammation of other muscles as well as infection. Now, how do you diagnose it? Well, this is all very easy for you, but to touch on the basics here. The main thing is that people have pain on the outside of the elbow. It's a very, very specific sign, so diagnosis is relatively easy. And there are some tests that I will demonstrate in a second, which I use, that can be elicit how to diagnose tennis elbow clinically. Okay? And these tests are the following. First of all, you go and palpate the outside of the elbow, right over the epicondyle. That's a fairly sensitive test. People have pain over the epicondyle. But there are some other tests as well. You've got to remember these tendons of the common extensor origin attach over the epicondyle, cross the elbow joint, then cross the wrist and all the joints here and attach to the hand. So it's quite unusual for tendons to cross two joints, all right? And these tendons are more predisposed to injuries. Hence, a lot of people get tennis elbow. Now, the tests have to reflect that as well. So quite often gripping is quite painful because when you grip, you are actually provoking all the muscles around your common extensor origin. So that is quite painful. There's a Cosen's test where you extend your wrist and again you resist, okay, where you get pain over the epicondyle. And similarly, extension of the middle finger can provoke pain over the epicondyle. And there's one final test where there's a stretch test, can cause pain as well. So a combination of these tests can give you symptoms over the lateral epicondyle. Not all of them need to be positive. And the take-home message is that most people will have some tenderness, but at least will have one or two of these tests positive. Now, there are several risk factors that we know of people getting tennis elbow. Of course, smoking, elevated BMI, in my opinion, diabetes is one as well, and there's a big genetic predisposition as well. But we know that environment has a lot to do with it as well. So we see it in manual workers, okay? We see it in people that use overuse. So a lot of people doing keyboards and sitting on a desk and typing all the time. They do tend to get excessive tennis elbow. And to be honest, there are more people sitting on a desk, typing away for hours in the end. So as a population, we probably tend to see in a clinic presentations from office workers more often than manual workers. Now, it's called tennis elbow, all right? But because we saw it in racket sports, right? And of course, racket sports with the gripping and so on and doing the movements does predispose to tennis elbow. As a population, a lot of racket sports people get them. However, if you compare the number of people playing tennis regularly compared to manual workers as well as office workers, the numbers of office workers and manual workers are actually massive, right? So as a proportion of patients coming to a clinic, we are more likely to see patients that have everyday jobs rather than getting tennis elbow from playing tennis. Although in my practice, where I look after a lot of sports people, I do tend to see patients with tennis elbow from playing actually tennis. So, moving on, how do we actually diagnose tennis elbows? Or in fact, if you were thinking about the other side, i.e. the medial side where the common flexor origin is, golfer's elbow, how do we diagnose that? Well, it's very simple. In addition to a clinical diagnosis, listening to the patient, examining them, which in my opinion gives a 90% accuracy of the diagnosis, you have the following modalities to use, right? X-ray, I X-ray everybody because it is very sensitive at picking up bony pathology, and more importantly, rule out some of the bad stuff, right? Occasionally people who have pain in bones and joints can present with very rare metastatic disease and so on. Now, this is probably not common in a general practice, but when patients come to see me with pain that has lasted for 6 months or a year, I see the tip of the iceberg, right? And the buck stops at me. So I tend to get these x-rays, and I'll be saying that at least 1% of the patients that I do x-rays on have an unusual pathology that would have been missed. Now, in addition, you can do an ultrasound and an MRI scan, and I'll go through some of my thoughts on that. And we reserve EMGs and so on for patients that we're considering a neurological cause or neuropathy, or some nerve being trapped. So again, I have that, but I don't use this to diagnose tennis elbow. I use this to diagnose other conditions that may be mimicking as tennis elbow. Fantastic. Any questions so far, guys? Good. Yes. So ultrasounds tend to look like this. The pictures don't do it justice, but ultrasound is a dynamic scan. So when you're actually doing it, you see these perfect pictures of what's going on. Here is the epicondyle, here's the radial head, this is a lateral aspect, and here we are measuring how much the thickness is of the epicondyle. But with the ultrasound scan, you can also use Doppler, which shows the flow of blood in and out, and that is a good way of telling us if there is tendinosis in the tendon, in the tennis elbow, or tendinosis in the lateral aspect of the epicondyle. Now, my modality of choice after the X-ray is actually an MRI scan, okay? Because unlike an ultrasound scan, it is not user dependent. So if you have somebody that you trust, please use an ultrasound scan because it is usually cheaper, especially in the NHS. But that person needs to be able to give you the right answer because you won't be able to see the pictures yourself and appreciate it. But with the MRI scans, you can, because MRI scans, you can actually see very deep inside the joint, so you can rule out any kind of osteochondral defects, any bony problems as well, and you can see the effects of the tennis elbow as well, i.e. what is happening to the lateral epicondyle. So here, for example, it is a MRI looking from the front, okay? And what you have is the humerus, you have the radial head, you have the ulna, and that's the medial side, and that's the lateral side. And that is essentially a relatively normal looking MRI scan. This is the common extensor region. The ulnar collateral ligament will be on the deeper surface, and these arrows are pointing, the outside arrow is basically the common extensor region, and this is pointing to the lateral collateral ligament. So that's what it looks like. It is a group of muscles that attaches on the outside of the elbow. Now, this is an injury. Now, there are two different things here I'd like to point out. On this view, what you see is that the inner layer, the lateral collateral ligament, is actually intact. But the common extensor region has a high-grade bursal surface and intrasubstance tear. So it's not a full thickness tear, but a fairly high-grade tear. On here is slightly different picture. So what you see on the one on the outside here is where the big arrow is pointing, is that the lateral collateral ligament, in fact, is torn, and the common extensor region has a partial articular surface tear. Now, this is where I come in, right? Because there are patients out there that have common extensor origin tendinopathy, i.e. tennis elbow, lateral epicondylar tendinosis, but they have not responded to any treatment. Okay. So you've got to figure out why are patients not responding to the normal treatment. Some of them have had really good physio as well. Clearly there are some attend here that have had nothing done apart from a steroid injection. But of course there are patients that have had rest, time, and is still not settling down, right? So this is where I come in and I do scans on them. Because once in a while, if you pick up somebody who has a ligament injury, it completely changes my management. Suddenly I'm thinking that the tennis elbow is likely to be secondary to instability or micro instability of the elbow due to tear of the collateral ligament. Now you know that every joint is stabilized by three main factors. There's a bony congruency of the joint, there is the ligaments, and there is dynamic stability provided by the muscles as well. Just like any other joint, the elbow is exactly the same. So if the ligaments are torn and you have the lack or decrease in the stability of the elbow provided by the ligaments because they're torn, then quite naturally it is easy to expect that the muscles will be overusing to help dynamically stabilize the elbow. And when that happens, what happens is that you overuse it and you're more prone to tennis elbow. So as you'll see later on, in most cases, I don't tend to operate on tennis elbow because there is no need to. But I have a lower threshold to operate on patients for tennis elbow, mainly to repair the ligament if the ligament is torn. So here is a picture of somebody that you rarely see. Everything is completely torn off, right? So the big hole there, and these common extensor origins lying here, along with the tear of the lateral collateral ligament. But that's quite rare. And I'm showing you some more pictures, but this is an interesting picture on the left. This is commonly what you will see when somebody's post-surgical, right? So something neat and clean like that is usually a post-surgical release. Again, I'd rarely do a post-release of the tennis elbow, and I'll allude to that later on my thoughts. And the last MRI that I want to show you here is a MRI from the front as well as a cross-section just to show you that when you have a tear of the star, where the lateral collateral ligament is, and a partial thickness tear of the common extensor region, if you look at it from a different view, you'll see that the bone is completely bare as well. So an MRI, in addition to an X-ray, in my view, in my practice, is a good way of not only confirming the diagnosis of tennis elbow, but more importantly, and this is the key message here, MRI helps me to actually manage the patient further. Because, like I said, diagnosis is relatively easy, right? This MRI is telling me how I'm going to potentially manage this patient. So now we're going to talk about why we need to treat tennis elbow. And the answer is pretty obvious, but of course, the main problem that patients complain of is actually pain, right? So we want to control the pain, and the pain can be quite disabling, right? So at the same time, we want to make sure that elbows don't get stiff, so we preserve the movement. We want to improve their grip strength and endurance, return to normal function. Yes, there are people that really want to go back to tennis, and we want to take them back to tennis, and we often achieve it. But really, when you talk about the normal person who actually wants to work, needs to earn a living, and can't do manual work or can't work in an office and type because they have tennis elbow, it can be quite disabling and quite financially disabling as well. Now, of course, there are lots of different ways of doing it, and I have just listed some of the things there, and I'm going to briefly touch upon them, right? First of all, the most important thing is that you need to try and modify the activity, right? So there are some people who are just doing things the wrong way, or people that can do things in a better way to allow the symptoms to settle down, right? Just remember, right? We're already thinking that tennis elbow is an injury, okay? And everything that we're trying to treat is trying to promote injury faster than overuse and other things trying to make the injury happen, right? So there's a fight between degeneration that happens on ongoing insults and ongoing manual work, etc., as well as regeneration, which is a natural process which we're trying to help with other modalities. So what we do as clinicians, and this is not surgeons only because physiotherapy is the key here, but what we do as a group of clinicians is to actually promote regeneration of the tendon. So yes, of course, in the short term, non-steroidals, analgesia, local anesthetic patches are good, but injections have been the main way of treating, and some of the injections that are mentioned are local anesthetic injections, steroid injections, PRP injections. There's blood by itself as well, there's botulinum toxins, and I'm sure there are lots more injections out there. Any place where there are lots of different things to try and manage the same problem usually suggests that we don't have a really good solution yet. Now, there is evidence-based therapy as well, and to a group of physiotherapists, I don't need to talk about how to rehab tennis elbow, but all I can say is that I appreciate you guys, right? Because end of the day, tennis elbow needs rehab, right? And my analogy that I give to my patients is that when they come and see me, from a clinical point of view, to confirm the diagnosis and to start any treatment. I rarely do surgery, but even if it was surgery or even if it was PRP, any treatment really gets you, in an analogy of a 100-meter race, it gets you off the blocks for the first 10 yards, and it's time as well as rehab that gets you to the end of the race. So, physiotherapy and rehab for tennis elbow is important no matter what you do, okay? And my personal view on surgery, again, we used to do so much tennis elbow surgery, we don't do it as much because we know that the evidence is not there for it. In fact, as mentioned earlier, that, I have a low threshold of only operating on patients that have had a ligament injury in addition, i.e. the lateral collateral ligament, but rarely for any other isolated common extensor origin injury, whether it's a partial thickness or a full thickness, is surgery required. So, do we inject? If yes, then what do we inject? Now, injections are generally safe, but remember, injections can cause pain, and there are lots of different things can go wrong with injections. There are certain things that you've got to be aware of. For example, the tendons are right there, so the injection itself can harm the tendon, either directly with the needle or the volume put in, or more indirectly with what you're putting in. And what I'm alluding to is basically steroids. But in addition, there are risks of fat necrosis and depigmentation, mainly with steroids. So if you haven't seen depigmentation, this is a good slide of it. If you can see that wrist, when you put steroids near the skin, where basically around hands and elbow, what you can do is the skin can lose its coloration and is more prominent, of course, if you have slightly darker skin. And the other thing is what's called fat necrosis. We all have a little layer of fat just underneath our dermis. And if you lose that, you actually, the bones underneath can become really prominent. So around the elbow, you have a little dimpling, scalloping of the skin, and some people don't like that either. And that's a role of steroids. And in most cases, not reversible. Now, the National Institute of Clinical Excellence does offer great guidance, a lot of things, but one of the things is that there is a cycle to these events, and as evidence comes out, these guidelines do have to be renewed. And one of the jobs that I have with my colleagues is to write to them to give them better evidence on how to manage tennis elbow. Because these guidelines, for example, mention that we should be doing steroid injections to tennis elbow. And as I'll show you a bit later on, the evidence is overwhelmingly against it. So what is the evidence against steroids, right? Well, there are lots of different trials, right? So this is a paper from 2014, which is a good read, a systematic review that tells us that what are the effects of local corticosteroid injections to the tendon, and the take-home message, it has a significant negative effect on the tendon, and therefore one has to consider that before injecting it. And again, there are many reviews like that go on to tell that steroids are not good. Now, the problem has been so far is, why are we using steroids if there is now evidence coming out? Why did we start using it, right? Well, it's funny that we use a lot of steroids in UK, which is not typical of most places in the world. But it is very clear that when patients come to see you, if you give them steroids, it will help. Of course it helps, because it is a massive anti-inflammatory localized in the area. So if you have pain from tennis elbow, your pain goes away. So typically patients come back 6 weeks later and say, "Doc, you were amazing, you were awesome. You gave me an injection and it's great. Thank you very much." Then a few weeks later they come back and say, "Doc, the injection was great, but the pain is now coming back. Would you mind injecting that again?" And the doc goes, "Of course we can, right? Because, who's to argue? Because even NICE says we can, right? So let's inject your elbow, right?" So they give another injection and they say, "Great, doc, that worked really well. Now I'm 6 months down the line. It only worked for like 6 weeks. Can you give me one more injection?" So of course we can, because 3 is a magic number. We don't know why, but we always inject 3 times. There's no science behind it. But the problem is, every time what's happening is that you're going in, you're taking the inflammation away. But if you remember, tennis elbow is an injury. Those collagen fibers are actually breaking apart, right? All right? And that's causing pain. So you're going in, you're just relieving the pain away with steroids, but what you're actually doing is probably doing more harm to the tendon, right? So most of the time, when steroids don't work, the problems becomes worse, okay? So yes, of course you want evidence for that, and we're going to talk about it. So Leanne Bessette published back in 2006, okay? So what she published was, and it's published in the medical BMJ, randomized control with 132 patients, and they looked at basically the effects of steroid versus no intervention. And the take-home message was that at 6 weeks, if you have no intervention, right, there are a significant number of patients still complaining because you haven't really done anything, right? But as soon as you give steroids, a lot of them are really happy, right? But at 52 weeks, not much is changing. But if you've done nothing, no intervention, there are more people that are happier. So in fact, back in 2006, a great paper tells us that if you've done no intervention whatsoever, that the outcomes are better than giving steroids at 1 year, right? This is what we want, right? We want long-term healing. So, but there were, people always criticize, even great trials. So they said, there isn't any physiotherapy here, etc., etc. People obviously need physiotherapy. So what? They did a trial with physiotherapy, which was published by Coombs et al. In 2013. And again, when you do steroids, half the people have recurrence rate, right? 55%. Even with steroids and physiotherapy, the range is the same. So it's not changing with physiotherapy, right? But look at the things where you've not done physiotherapy, right? So basically, what you've done is a placebo injection with physiotherapy, only 5% recurrence rate, right? So the summary of this slide is that, when you have, a placebo injection or physiotherapy with placebo injections, the outcomes are much, much better than giving steroids with anything else, right? So steroids, even with physiotherapy, are not good news. So let's combine the two data of these two great randomized controlled trials, and this is a good summary slide for you to remember, right? So basically, we're looking at recurrence rate. So if you have patients with tennis elbow that has not responded to treatment, and you give them steroid injections, at 1 year, 55% of them are still in pain, right? Now, one side of you is thinking, that's not bad because we cured 45%, right? But hey, let's wait, right? So what if you gave steroids with physiotherapy? And you can say, 54%, kind of around the same. But if you do no intervention, so you just see these patients and you just completely ignore them, right? Tell them that we're not going to do anything. They don't like it, but you ignore them and you see them at 1 year's time and they say, Doc, thank you for not doing anything, because only 9% of them are still in pain, right? Whereas with steroids, a much higher percentage are in pain. Now, if you do physiotherapy, the numbers are around the same, right? So it's very clear, 55, 9. If you do steroids, at least more than half patients will be still in pain, whereas the number is less than 10% if you not do steroids. Now, initially, this looks like the physiotherapy is not doing anything more over no intervention. So I want to reassure all of you that this is not the case, because the last thing we want is some committee saying physiotherapy is not helpful. And here's a slide that I want you to have a look at, right? So it's a busy slide, but I'll just go through it very briefly. The blue line is basically with wait and see. Sorry, blue line is corticosteroids. So what we tend to see is that there is some effect and then it kind of weans off there, so not much help, right? Now, what I want you to concentrate at is the physiotherapy line, which is orange, okay? And the green line, which is wait and see. So although at 1 year, the results are pretty much the same, what you notice early, 6 to 8 weeks, is that the physiotherapy gets you better faster, right? So although the end results are the same, by doing rehabilitation, you get there faster, okay? So it's important take-home messages for this one. Steroids not great, but physiotherapy early is probably beneficial. So when I see patients, right, when I've done my diagnosis, make sure there's no ligament injury and so on, I don't consider any injection before I tell them, have you had good physiotherapy? I show them the exercises to do myself, and I make sure that they have a good physiotherapist to give them a few sessions on how to do exercises, and I tell them to have some patience. So, use of steroids in tennis elbow promotes the symptoms to last for a much longer time with a higher recurrence rate when compared to no intervention or physiotherapy. Now, what about platelet-rich plasma, right? So for those of you who don't know what PRP is, it is essentially we take your blood, we concentrate the growth factors, take away all the red blood cells, and in our case we take the leukocytes away as well. So you're taking a plasma rich in growth factors, and then you're injecting it in places where there is an injury. Now remember, tennis elbow is an injury. What we're trying to do is promote healing. Is there a role for PRP? And with us there is, because there are patients who don't have a ligament injury, who have tennis elbow, who have had good physiotherapy, who have modified the activities, and they're still not getting better. Is there something that we can do to promote further healing? And in this cohort, PRP is something that we recommend, right? So we are taking the really difficult patients and we're offering them PRP. What's the evidence for it? Well, interestingly speaking, all the evidence initially for PRP is comparing PRP to steroid injections, right? Now we know steroids are bad, so that's not a fair comparison, right? It's like, asking a heavyweight champion to fight against a lightweight, right? So here we are. But there are studies, good studies. This is from Netherlands with a 1-year follow-up and then a 2-year follow-up published, which shows that PRP is massively superior to steroid injections in tennis elbow. This is the same group publishing at 2 years. Now, interestingly speaking, what I found in this paper was that the benefit which was given to patients in the initial injections of PRP was sustained even after the first year, up to 2 years till the study went up to. Now, this study is slightly different, right? So this study didn't look at comparing PRP to steroids. In fact, what it did was, this is a study from Rothman, I believe, and in America, and what they did was they compared PRP against dry needling by itself. So patients are having needling with and then without PRP, right? So both are having needling, some are having PRP. And even in that they found that the PRP is doing better. That's quite an important message, right? Because a lot of times when patients have injections or PRP or any kind of surgical thing, the take-home message is, well, maybe you're inducing trauma, and when you're inducing trauma, you're increasing higher blood flow. Of course, and that's what promotes healing. Yes, that is true. But in this case, both of the patient groups are having same amount of trauma, but one is having the additional PRP, and the PRP was doing better. And there are many other studies which go and talk about the benefits of PRP against steroids, right? So, and I'll just leave them there and flip through them, but the message is exactly the same. There is no lack of evidence there, okay? Now, this is, again, a study which compares PRP against local anesthetic injections. And again, the study shows that PRP is superior. There is, PRP against looking at steroids, but in this case, in addition, what they did was ultrasound evaluation to actually look at the tendon, which is quite a nice way of doing it. And they found was that with PRP, as opposed to the steroids, the tendon showed ultrasound evidence as well as clinical evidence of healing, which is what we want to see. And steroids obviously did not heal. There are other ways, as you know, of treating tennis elbow. So this is one looking at shockwave therapy compared to PRP. Both results were good, but PRP, according to the results, got the patient there faster. And what about surgery, right? So, this is a good paper, but there are other papers around it as well. Interestingly speaking, comparing surgery and PRP, the results were the same, right? Which is fine, but why would you do then surgery? Because why would you put the patient through surgical intervention with significantly higher costs unless it's necessary? And in my views, I reserve surgery for patients that have failed rehab if they have a ligament injury. And there's a good reviews on the use of PRP, and this is by Adam Watts in Wrightington, so if one of you wants to read it. So we're coming close to the end. Thank you for your patience, and this is one of the last slides, a very busy slides, but it's an important slide. Again, I'd like to thank my colleagues at USER, especially Leanne Bessett for actually providing this slide to me. What this slide does, it has 3 columns. One is the short term, the middle one is the intermediate, and the last one is a long-term column, right? And what it's doing is basically lots of different trials on this axis comparing the effects of steroids against everything else. So this is steroid against no intervention, steroid plus physiotherapy versus just physiotherapy alone, steroids with physiotherapy, with other placebo injections, with platelet-rich plasma. So these are all different good trials, and this is a very interesting result, and this is what I use to actually tell my patients about, when they come back and say the steroids worked for a few months. It's not working because what's happening is, with these trials, as you can see, that if you give steroids, this line is basically the line which compares steroids against the modality of treatment. So if you're on this side of the line, that means the steroid is winning. On the other side of the line, the other treatment is winning. So initially, in short term, what happens is, when you do steroids does better at relieving pain than any other treatment, right? But if you follow the same patient's intermediate time frame, only one of all these trials show that steroid is winning, because steroid is actually losing against every single intervention, even doing no intervention. And then of course in long term, those trials that do go up to long term, steroid is a clear loser compared to any modality of treatment as well as no treatment. So, my summary of how I manage tennis elbow: please confirm the clinical diagnosis. There is imaging that can help you do that, but mainly it's a clinical diagnosis. Everybody gets physiotherapy, rehabilitation, okay? This is the key, and that is with or without any further intervention. Those patients that have not responded to just physiotherapy by itself, I do inject PRP, whether this is in my NHS practice or my private practice, it's all the same, and I don't inject steroids. And now the surgery, of course, there are lots of different surgeries, but usually I reserve in my practice surgery for those patients that have a ligament injury to repair the collateral ligament. If I am doing something to the common extensor origin, I am now not only doing a release, which is a traditional surgery, but since it's a tendon injury that is torn, I am repairing it as well using a suture anchor, and we're finding that the patients that have had surgery to repair the common extensor origin are doing better and healing faster. But overall, as I said, I see the tip of the iceberg. I see patients that have not done with tennis elbow well somewhere else, so they're a difficult group of tennis elbows. And even in that group of tennis elbow, I probably operate on less than 8% of my patients. So anyway, thank you so much for your time. If anybody wants to get in touch with me, then those are the numbers for the clinic. I'm on Twitter as well. Those of you that use Twitter, please feel free to get in touch. Thank you so much.